Hello and welcome to the topic Ankylosing Spondylitis in the Rheumatology module. By the end of this topic, you should be able to define Ankylosing Spondylitis, explain the pathophysiology of Ankylosing Spondylitis, describe the features you would see in Ankylosing Spondylitis, outline the investigations done to diagnose this condition, and finally, discuss the management of Ankylosing Spondylitis. Let's get started. So what is ankylosing spondylitis? The term ankylosing refers to the word stiffening, and spongy refers to vertebra, and itis is inflammation. So ankylosing spondylitis is a chronic inflammatory disease that affects the vertebral joints, which can also affect the eyes and blood vessels. This disease eventually leads to stiffening of the spine, and it is one of the seronegative spondyloarthropathies because rheumatoid factor is not present in this condition. Ankylosing spondylitis is a HLA-B27 associated spondyloarthropathy. It has a polygenic inheritance, and this HLA-B27 gene codes for a specific type of major histocompatibility complex, or MHC class 1. The CD8 T cell, which is also known as cytotoxic T cell, uses its T cell receptors to bind to the antigen presenting by the MHC class 1 molecule. When the cells recognize a foreign molecule, they use cytokines to signal other immune cells to migrate to the joint capsule and the joint space that's under attack, cells like neutrophils. Eventually, the neutrophils release cytokines like tumor necrosis factor alpha or TNF-alpha and interleukin-1, which worsens the inflammation. This chronic inflammation of the intervertebral and facet joints of the spine eventually leads to the destruction of the joints, and next, the fibroblasts replace the destroyed joint with fibrin. Eventually, osteoblasts get activated and a process called ossification will start, which is when fibrous tissue turns to bone. In the beginning, small bony outgrowths will form at the joint edges, and this is called syndesmophytes. This makes the spine immobile. Let's look at the features of ankylosing spondylitis. Typically, a young man who presents with lower back pain and stiffness of insidious onset. The stiffness is usually worse in the morning and improves with exercise. The patient may experience pain at night, which improves on getting up. Clinical examination would reveal reduced lateral flexion, reduced forward flexion, which is demonstrated with the Schober's test. Here, a line is drawn 10 cm above and 5 cm below the back dimples or the dimples of Venus. The distance between the two lines should increase by more than 5 cm when the patient bends as far forward as possible. Anything less than that would indicate a positive Schober's test. Another finding that you would also expect to elicit during the examination would be reduced chest expansion. Other features of ankylosing spondylitis are the other A's, such as apical fibrosis, which can lead to progressive shortness of breath because the total lung capacity reduces due to fibrosis, anterior uveitis due to the inflammation of the particular area of the eye, which are the eyelids, cornea, iris, ciliary body, and the anterior as well as the posterior chambers. The inflammation of the adventitia and the intima of the aortic root causes fibroblastic reparative response, and this leads to aortic root disease causing aortic regurgitation. Other associations to ankylosing spondylitis are Achilles tendonitis, AV node block, amyloidosis, and cauda equina syndrome, as well as peripheral arthritis, which is seen in 25% or more common in female. Plain X-rays of the sacroiliac joints is one of the most useful investigation to diagnose ankylosing spondylitis. Radiographs may be normal in the early disease, and changes might be seen only later part of the disease. Among the changes that can be appreciated include sacroiliitis, which is indicated by subchondral erosions and sclerosis, squaring of the lumbar vertebrae, bamboo spine or vertebral fusion, which can occur late and quite uncommon, syndesmophytes, which occur due to ossification of outer fibers of annulus fibrosus. This is a tramline appearance which happens due to the syndesmophyte growth between the margins of the vertebrae. And chest X-ray would reveal apical fibrosis. A spirometry may show a restrictive defect due to a combination of pulmonary fibrosis, kyphosis, and ankylosis of the costovertebral joints. Here are many other radiographic images showing the abnormalities in ankylosing spondylitis. Ankylosing spondylitis can also be diagnosed using MRIs. There is typically erosion and narrowing of the joint space earlier on, and the joint fusion happens later. MRI is more sensitive than an X-ray, and it's the best method for early detection. So what are the findings that you'd expect to see on an MRI? This will include bone marrow edema, which is the earliest change visible on MRI, squaring of the vertebrae, erosion of the apophyseal joint, and obliteration of the sacroiliac joint. The current British Society for Rheumatology recommendations state that the modified New York criteria can be used to diagnose ankylosing spondylitis. And among the clinical criteria include low back pain, which is present for more than 3 months and improved by exercise but not relieved by rest. There's limitation of lumbar spine motion in both the sagittal and the frontal planes, as well as limitation of chest expansion relative to normal values for age and sex. Among the radiological criteria in the modified New York criteria is the sacroiliitis, which is seen on X-ray. So diagnosis is made as a definite ankylosing spondylitis if the radiological criterion is present plus at least one clinical criterion. A probable ankylosing spondylitis diagnosis is made if 3 clinical criteria are present alone or if the radiological criterion is present but no clinical criteria are present. As for management, we would follow the 2010 EULA guidelines, which suggest the non-pharmacological approaches such as lifestyle modification, and this includes encouraging regular exercise such as swimming, as well as physiotherapy. And for pharmacological approach, that would be the initiation of NSAIDs, which is the first-line treatment for pain management in ankylosing spondylitis, anti-TNF therapy, and this is the second-line agent. And this is only used for patients with severe ankylosing spondylitis which have failed to respond to NSAIDs. In more severe cases, disease-modifying anti-rheumatic drugs or DMARDs like sulfasalazine and methotrexate can be helpful. Newer therapies called biologics can also be useful because they block the actions of cytokines like tumor necrosis factor alpha and the interleukins. Surgery can repair damaged hip and knee joints, but spinal surgery is typically considered risky and is rarely performed. Let's summarize. Ankylosing spondylitis is an autoimmune condition associated with the HLA-B27 gene, which attacks vertebral joints, destroying and further leading to ossification. This gives an appearance of a bamboo spine on X-ray or CT scan. It can also affect the eyes, aorta, tendons, and the lungs. Affected individuals typically complain of low back pain and stiffness with positive Schober's test on examination and classic findings on radiographic imagings. A definite diagnosis is made if you have one radiological criteria with one or more clinical features which are suggestive of ankylosing spondylitis. Management can be largely divided into non-pharmacological and pharmacological ways. Apart from exercise and physiotherapy, analgesics and disease-modifying anti-rheumatic drugs are largely in use to control the exacerbation of the disease and delaying progression, ensuring a better disease control. We have come to the end of this topic. Thank you.